Assalamualaikum warahmatullahi wabarakatuh and good morning, distinguished guests, esteemed speaker and also valued participant. On behalf of the organizing committee, it is my honor to welcome you to the 7th Emergency Medical Seminar Series, an annual tripartite program centered on the critical, timely theme, toxin, trail and terrain, emergency medicine in changing ecosystem. My name is Fahana Fatima and I will be your moderator for today's session. For this episode 1, our week is mainly on analytical and clinical toxicology. This event is proudly organized by Universiti Kebangsaan Malaysia, Universitas Brawijaya, and the University of Philippines. As the EMSS webinar enters its 7th edition, it's continued to serve as a platform for dialogue, knowledge exchange, and professional growth. We encourage everyone to participate actively and make the most of today's session. The flow of today's webinar will be as follows. We will begin our webinar with 3 lecture sessions. Each session has been allocated for 45 minutes each. And after the lectures, we will proceed to an interactive forum for question and answer, followed by a fun and engaging Kahoot session to wrap up the program. There are 3 speakers for today's webinar. We have Prof. Madya, Dr. Khairul Osman, Dr. Yao Yiju, and also Dr. Hartadi Tanjoyo. We will begin our webinar today with our first session. Our first speaker is Prof. Madya, Dr. Khairul Osman. To begin our webinar, the first topic for today is Malaysia's battle, the rise of illegal drugs, NPS, and also polydrug abuse, which will be delivered by Prof. Madya, Dr. Khairul Osman. A little introduction about Prof. Khairul Osman. He's an associate professor with over 20 years of expertise in forensic science, currently leading the forensic science program at UKM Faculty of Health Sciences. He's a proud alumnus of UKM, where he earned both his Bachelor of Biomedical Science and PhD in Forensic Science in UKM. Dr. Khairul boasts impressive certificates, including Certified Ethical Hacker and Certified Ethical Forensic Investigator from EC Council, and Examining Evidence from Johns Hopkins University. His specializations are diverse, covering criminalistics, digital forensics, and toxicology. Dr. Khairul is a cornerstone in the field, actively involved in crime scene investigation and instrumental in developing standard procedures for maritime crime scene investigation. He is a trusted advisor for investigating officers and a go-to expert for complex cases across Malaysia and beyond. With over 100 published journals and research books, his significant contributions have earned him numerous accolades at both faculty and university levels. He is currently head of the UKM PDRM NPS service that identifies the emergence and spread of new psychoactive substance in Malaysia. Without further ado, Prof. Khairul, the floor is yours.
Thank you. Thank you very much. Good morning, everyone. As mentioned by our MC today, my name is Associate Professor Dr. Khairul Osman. I'm a lecturer in Forensic Science Faculty of Health, UKM. I'm based in Bangi, Selangor. My specialty is in crime scene investigation and forensic biology primarily. I'm currently the coordinator for RMC or PDRM UKM NPS Intelligence Lab. It was formed in 2023. Basically, the function of this lab is to monitor the emergence of NPS, understanding the market volatility of illegal drugs throughout Semenanjung Malaysia, which especially with emphasis on hotspots areas. Number 3 is to recognize drug chemical fingerprints and identify variation in illegal drugs manufacturing process. So basically, my talk will be giving you an insight on what you'll be seeing in 2 to 3 years in relation to drug overdose in ED. Due to security reasons, some results has been generalized, but I think my presentation today will be sufficient to provide you some idea on what you will be facing in the near future. So let's go to the actual gist of my talk. So, what will be covered? I'll be covering only 5 sections, which is the definition and scope. This would cover the laws that encompass illegal drugs, the prevalence, the NPS problem in Malaysia, and the mixture of illegal drugs, legal drugs, and NPS in the form of polydrugs, and what should you do? So in definition and scope, I'm going to cover just into illegal drugs within the Malaysian population. I'm not sure whether they have foreign counterparts here, but mine will be locally on the local ones, the ones that we have managed to collect, synthesize, and understand. So basically, for classification of illegal drugs, we refer to our 1952 Act, which is the Act 9234 Dangerous Drug Act. Now, the scope of this act, basically, it's an enforcement act in which it regulates the import, manufacture, sale, and use of opium, dangerous drugs, and related materials. The regulation is more encompassing, is fines not exceeding 20,000 ringgit, but you will find that if you go through the act in detail, you find that some of it will only just a maximum of 10,000. But in overall, you'll see the maximum is 20,000 in some sections. And there is imprisonment for a term of not exceeding 5 years, or there is a death component in there in which it is under review. For the Dangerous Drug Act, we can divide it into 6 parts containing 50 subsections. It's quite a lot, and 3 schedules. We are adding the 4th schedule soon, and we tend to do amendments nearly every year. That's why you find there's about 47 amendments, and most of the amendments that we add in is basically new drugs that have been found to be highly toxic and causes hallucination and etc. So the parts within the act is the part 1, which is the interpretation and definition. Part 2 is how we control for raw opium, coca leaves, poppy straws, and cannabis. Part 3 is control of prepared opium, cannabis, and cannabis resins. Part 4 is the control of certain dangerous drugs. Part 5 is control of external trade. Part 5, ancillary and general positions. And the last one is the schedules, which we tend to add from time to time on new drugs. So as you can see in part 2 and 3, it more defines on what we call established drugs. But part 4 gives us wiggle room to add new drugs into the act itself. Now, for drugs that are not listed in the Dangerous Drug Act, we will rely on our Poison Act, which is the Poison Act 1952. This act has less what we call teeth in it, in which enforcement is, we can do the enforcement, but the jail time is not that much. So the scope basically regulates the importation, process, manufacture, compound, storage, transportation, sales, and use of poisons throughout the country. The poison list is to classify different type of poison based on their strength, property, which we do not really need the parliament approval. We can use the minister to amend it, which we allow us a little bit of wiggle room in terms of adding new type of drugs quickly. And licensing is, the act outlines the license requirement for businesses and individuals involved in the handling of poisons. So these 2 acts basically is what we call the Enforcement Act. Now we have a third act, which is the Drug Dependent Treatment and Rehabilitation Act 1983. This one addresses drug dependency as a health issue rather than a criminal one. So it is basically, we call it a Rehabilitation Act. It allows individuals to be sent to a rehabilitation center or placed under community supervision, which is deemed by the court, suitable by the court. And this can either be done through a court order or on voluntary basis. We do have about 10-20% who volunteer to go into the rehabilitation center. And usually it is being persuaded by family. And then for options, it helps them to avoid criminal prosecution under under the Dangerous Drug Act. Now let's have a look at we have the act in place. The act has already defined the type of drugs that we consider are dangerous. So now we're going to look at the prevalence of illegal drugs in Malaysia. So this is the latest data for 2025. We collected the data in May 2025. So these are the prevalence of drugs or poisons among drug addicts in 2025. As you can see that one is quite a big mixture. Some drugs contain chemicals, some drugs contain illegal drugs, but non-NPS, which are, for example, cocaine and heroin. And then we will have the legal drugs, in which drugs that has been misused. And then we have the new ones, which is the NPS. Now, and please take note that the ones that I've listed as NPS at 67.1% are NPS that are registered by the Dangerous Drug Act, and those that are not registered by Dangerous Drug Act, but are reflected by either the um, uh, UNODC, United Nations Drug Controlling Center. And then we, of course, have those that are listed in the Poison Act. Now, if you look closely again at the data, when you add up the percentage is above 100%. This is because a lot of the drug addicts that we sample will contain multiple drugs. Usually we'll find that they will have about 5 to 10 types of drugs in their urine. And let's see, middle of last year, we managed to get a drug addict with at least 20 type of drugs in its system. So as you can see, they tend to take a lot of other types of drugs based on the price of the current drug and also their preferences. Right. Now, this is the prevalence of drug classification of drug addicts. As you can see that it covers from antiseptic, anesthetic, amphetamines, cations, hallucinogens, antidepressants, and anti-anxiety and mood stabilizers, analgesics, expectorants, carton alkaloids, opiates, anti-inflammatory, antihistamines, and even our erectile dysfunction drug analogs. All right. Now, if you look at the leftmost, part, you'll find that there is a high, nearly 70% of methylxanthine in the system. Now, this is not actually a drug, but it's just a nice thing to see. So, methylxanthine is a metabolite, and this methylxanthine is quite high among the Malaysian population compared to other countries. The reason is that methylxanthine is a metabolite of three components, or from three sources. One is caffeine, the other one is theophylline, the third one is theobromine. The first one is caffeine, right? So caffeine is found in coffee, tea, and many energy drinks, Coca-Cola, and etc. Caffeine is the most widely consumed psychoactive substances in the world. So it has a stimulatory effect, and as you can see, Malaysians drink a lot of coffee. Now, the second one is the source of methylxanthine is the theophylline. I think everyone knows it's a bronchodilators. It's good for asthma and COPD. And then the third one is, interestingly, Malaysia eats a lot of chocolates. So it's from the theobromine in the chocolates. So that when the theobromine metabolite, it will form methylxanthine. And although it has less stimulating effect on the central nervous system, and is a diuretic and heart stimulant, Malaysians tend to eat quite a lot. And that's why you see that whenever we run our urine sample, we'll find that methylxanthine is present in nearly most of our samples. And basically, it has no impact on drugs, actually. But it's quite interesting to see Malaysia is consuming quite a lot of it. Right. Now, I'm going to go into each of the section which I have highlighted here. All right. Which are the most common drugs that you see. So if you look at antiseptic, the most common ones that we do see coming up is benzodiazepine. For anesthetic, is the morphine drug. Now, this one would cover about nearly 75% of cases of drug addicts. We do see ketamine quite high in the last 4 years with lidocaine and methoxyketamine, but we see that these three percentage has been going down for the past 1 or 2 years and being replaced by morphine. So basically, morphine is a coming trend, and you should see in the next 2 years that it will be present in most of the drug rally that come in. For the amphetamine group, these are the list: 2,5-DMAs, the TMAs, 4-MMAs. Of course, you have the amphetamines, and then you have methamphetamine, fluoromethyl penidate, methamphetamine, and lastly is the polydrine. Now, most of the common and about 60% of the amphetamine cases for drug addict, we do find the top four to be the most common ones, with the highest is the 2,5-DMA. Now, if you look at the 2,5-D, amphetamine is the most common, or the old drug, we call it, the old world drug. The new variation is the 2,5-DMA, and as you can see, amphetamine used to be on the top rank, and now it has slowly moved down, and 2,5-DMA seems to be coming out due to its relatively easy to produce because it's a synthetic drug. And also, it tends to have a much more potent effect compared to the amphetamines. For cations and phenethylamine subtypes, it is a very long list. There's about 30 type of drugs which we have found to be present in among drug addicts, but the most two which are the most famous ones are the piperonopiprazine group and the 2-ALs. So these two are quite the most common ones that comes in when we catch the drug addicts. Okay, for the hallucinogens, it's again a very long list, but it more centers towards the what we call the 2C family. You see the 2CD, 2CE, and 2CH. These would cover nearly 90% of most cases. Why the hallucinogens for 2CDs and 2CE, D, E, and H is quite high. Basically, again, it comes back to the synthesis process. They are quite easy to make, and when you want to import them, you can import them in separate components. In other words, you can import a raw material, legal raw material, and when it comes into Malaysia, you can synthesize it in an illegal clandestine lab. And then most of the manufacturing process will involve synthesizing all three components at the same site itself. So we tend to see, for example, 2CDs, 2CE, some 2CD drugs. When we do analyze the 2CD drugs, you sometimes see trace amount of 2CEs and 2CH in the system itself. For antidepressants and anti-anxiety and mood stabilizers, we have the LOL family, which is the azacyclovir, bisoprolol, and bunitrolol. These are the most three common ones. And of course, again, as I've said, you will have other things. Now, gabapentin was used to be quite used to be quite famous in consumption about 5-10 years ago, but it seems that the drug addict seems to prefer the LOL family compared to gabapentin nowadays. Now, is the new psychoactive substances, or NPS, a problem? Okay, before that, let's do some definition again. Now, how we define new psychoactive substances? Basically, we define them as drugs that have been designed to mimic established illicit drugs, such as cannabis, cocaine, MDMA, and LSD. So we call them cannabis, cocaine, MDMA, and LSD are we call old chemicals. The new chemicals are replaced those that are banned. because all cannabis, cocaine, MDA, and LSDs has been put into the Drug Act. So how the drug manufacturers, illegal drug manufacturers circumvent the problem is they look at chemical formulas that are not listed in the Dangerous Drug Act or the Poison Act. So how good are the clandestine lab creating the drugs? We do see some changes to the chemical side chain of the chemical compound around about every 2 months to 3 months. So it is a cat and mouse operation in which we need to identify new compounds that come up. The only thing is that we do find that because they need to create new drugs quickly, you find that the purity of the drug is very low. Unfortunately, the effect is quite high and the toxicity is extremely high. But how they compensate by the low purity is that because the effect is quite high, they seem to be able to calculate is that they can reduce this amount of size or the dosage of the tablets that contain the NPS, but you will give similar effect to the old type of drugs, which is the cannabis, cocaine, MDA, and LSD. Of course, they do need to modify it from time to time by adding other drugs to make the drug what we call less sharp, because from what we understand from the drug addicts is that when you start taking NPS substances, drugs, the effect is quite sudden and it's quite sharp. And some of the drug addicts do not prefer that. They would like it to be a bit on the softer side. So a lot of the illegal drug manufacturers tend to mix a few drugs together. And this one will be discussed in the polydrug section. So now let's look at the prevalence of positive NPS among drug addicts caught in 2025. These are the areas, and I think this will give you a rough idea on what you expect that will be coming to ED. If you can see closely, Brickfields has a low NPS percentage, which is 33.3. And you find that nearly all drug addicts that are caught in 2025 from Ipoh and Seto will have NPS in its system. We have a moderate area in Petaling Jaya and Wang Semaju. Now, basically, what we roughly can understand is basically if the area where we catch the drug addict are a well-to-do area, you will find that the percentage of NPS is not high compared to other regions or the next region or next area. If you have a lot of low-income population within that group, NPS percentage will be very high. For those areas which are well-to-do areas, the NPS is low, but it will be high in terms of old drugs, for example, heroin and cocaine. Right. But basically, we do find that we did one study, which I'm not presenting here today, is that right now NPS prevalence throughout Malaysia is about 78%, and it is trending upward. So we do see by 2030, you should see 100% positive NPS in drug addicts in all areas. Okay, the prevalence of NPS among drug addicts caught in 2025, as you can see, the highest is, again, like I've mentioned, is the Mopolin drug, which is 52.1%. And then you have the MDMC, 2CH, and then the p-hydroxyl methamphetamine. This is a metabolite for meth. It is not NPS, but I would like to highlight it because meth is a well-known drug that we do see a lot in our investigation. And then pentylone, 2CDs, and etc., which I've shown here. All right. Now let's go one by one on this section. So you're going to see is you see this one quite often, followed up by this one, followed by this one. Of course, you follow it up by the meth, and then the pentylone, the hallucinogenic agents, which is the 2CDs, and etc. So I'm going to go to each of them, which is the morpholine. Morpholine is basically a dissociative anesthetic. It is an analog. I think it's well known. It's known as PCP, ketamine, diphenhydramine. It is a morpholine analog of 2-MeO PCP. Now, when the sorry, when the suspect consume this type of drug, you see characteristic of PCP, but you see the effect in more extreme way. All right. So if you look at here in the symptom, these are typical PCP symptoms, which is the disassociation, detachment, out of a body experience, derealization or depersonalization, hallucinations, delusion and paranoia, confusion and disorientation, erratic or bizarre behavior, euphoria, anxiety. We do see panic attack comes first, anxiety then followed up by panic attacks at higher dose and cognitive impairment. As you can see, it is a typical PCP characteristics, but you do see that the effect to emerge quite fast and to be sustained at a longer time compared to PCP. And for the signs for cardiovascular, you do again tachycardia, hypertension, in which it is the sympathetic action, numbness on extremity, ataxia, slurred speech, nystagmus, and muscle rigidity or spasms. Overdose and severe toxicity. This one is seen quite often because they think that the drug contains pure PCP rather than the morpholine, so they tend to take the same dosage, and so they can easily reach toxic dose, and you tend to see a lot of overdose and severe toxicity among the drug addict that consume these type of drugs. So you see agitation, but a violent behavior. You won't see it too much at ED because this would be, the police would calm them down at site. You have hyperthermia, so you tend to see a lot of them. If you go to the crime scene, you'll see them wearing underwear or shorts without any clothes or any shirts, or just using singlets. And then catatonia, and then seizures and coma. For MDMC or methylone, the second most common ones is an anectogen and a stimulant drug. It belongs to the family of cation, or what is known as bath salts. It's related to, again, MDMA, or what is known as ecstasy, but it is a modification. So we do find is that when you ask the drug addict what they had consumed, they tend to say that they took either ecstasy or Molly, but in actual fact, it's actually the brand is the same, but the manufacturers has spiked it with either MDMC or replace it totally by MDMC. So they know it's ecstasy, but they don't really care the content. So you have to be careful on that one. So there's some modification. For example, if the drug addict is a bit knowledgeable, they probably call it as BK-MDMA. This would indicate that it is a MDMC. Again, we do see methylone in other products, marketed products, and they are being relabeled again as bar salts, plant foods, or research chemicals. For 2CH, again, it is as I said, it's a psychedelic phenethylamine. It is a MAO inhibitor. It causes visual and auditory changes. You see this quite clear when it comes to when they arrive at your ED. You see agitation, hypertension, tachycardia, and hyperthermia. We tend to see 2CH quite often to be a bit more severe when it's added together with alcohol, MDMA, or methamphetamine. So we expect to see them taking suspect. For us is suspect, for you is patients that come into ED during when they attended parties or raves. So they usually tend to take alcohol with 2CH, or usually all four: alcohol, MDA, and methamphetamine, and 2CH. And then there is and you find that there is a lot of hypolocomotion when they're taking at high doses, or when they are taking it together with alcohol. The last one is pentylone is a cationone family. It is a stimulant. Again, it's called as a MySOT. It produces similar effects to more common stimulants, which are methamphetamine or ecstasy, but it appears to be a bit more long-acting. So usually, if you have ecstasy, you see about 3 to 4 hours. Depends on who has taken it and whether they are first-time users or occasional users. But for pentylone, you tend to see the effect to be extended to about 1.5 to 2 times the usual time, the usual duration. They tend to have pentylone is quite expensive, so we found that they tend to be in blend with other cations, including the PBP, MDPV, and 4-MEPPP. Again, psychological is the same with other NPS, which is the paranoia and agitation, and physical or behavioral will be the insomnia. The characters of insomnia will continuously be present even after the washout of the drugs. Now, let's look at the polydrug. Now, polydrug is, as I've said, they are, as I've listed out, there are the list of most of the common drugs that you tend to see in drug addicts. Then they tend to, and some of the drugs tend to be laced with other materials. They have cutting agents, and then they will additional drug into the tablet to make it so that the symptoms or the characteristic or the feeling that you get when consuming the drug will be unique. So let's go to the first one, which is our morpholine. Now, this is a spider chart. So it shows the type of drugs that are present with morpholine. But if you can look closely at the value, this one starts with 0, this one ends with 0.6. And all are less than 0.6. This indicates that if it is less than 1, value of 1, then you see that the drug is rarely added together with the ones that I've listed out in a circle. So in essence, morpholine, if a person consumes morpholine, you tend to see that they actually take the pure form of morpholine. Why they take the pure form of morpholine? Because morpholine is quite easy to synthesize, and the addicts tend to, when they consume morpholine, the effects are quite acceptable to most drug addicts, and so they do not require the additional of other drugs. Okay, for methylone, this is how you see is basically like raw salt crystals, all right, of stones, white stones. You see that methylone is mixed with 2 MECs and 3 MECs. And 2 MECs and 3 MECs why you tend to see that is basically when they do the manufacturing process, they tend to create 2 products. One is methylone, and then after they finish production of methylone, they will produce 2 MECs and 3 MECs, and then they do not clean the area, and then they go back to creating the synthesize the methylone, and you tend to have a cross-contamination of the drugs. And that's why you see methylone, 2 MECs and 3 MECs together. Usually in a ratio of methylone will be the major one, and then 2 MECs and 3 MECs will be in a ratio of 1 to 1. For 2CH, this one is more characteristic to Malaysia. We do see reports in overseas, but Malaysia that drug addicts seems to gravitate towards 2CH rather than other compounds. And usually 2CH is usually MDMA will contain 2CH and probably 2CBs. And kadang-kadang they tend to say it's as ecstasy, but it is not. It's actually 2CH. And these are the characteristics you see. It's a white powder, and it's quite fine. For pentylone, you tend to see two compounds present here, which is dibutylone and mescaline. Now, dibutylone and pentylone will elevate extracellular dopamine and stimulate motor activities. So if you are thinking pentylone does cause stimulation of motor activities, but because the presence of dibutylone, you see that the motor activity will be very elevated. And so, but because pentylone and dibutylone react on the same receptors, you see that the drug has a much severe effect, and it's a significant risk for the abuse. Both have near similar chemical structure, and we think it is a byproduct of chemical reaction when you want to create pentylone. Again, this is a speculation because we were not able to obtain the formula on how to create the pentylone. So mescaline, also known as mescaline and mescaline, is a naturally occurring psychedelic protoalkaloid of the substitute phenethylamine class. Basically, it's found in cacti like peyote. We don't have peyote in Malaysia. They are more in Mexico. But we don't, based on investigation by the Royal Malaysian Police and also by customs, we don't see any large importation of this type of of mescaline into Malaysia. So we suspect that they're bringing in small quantities lah. And some of them tend to take mescaline as is on its own, using what is known as a microdosing. But we do also again find them in pentylone. We don't know why. Probably one is either they're bringing mescaline from overseas as per se, or they are synthesizing it in Malaysia itself. Police are investigating this issue. Now, for suspects that take mescaline or taking pentylone, which contains mescaline, you see that they will have a paranoia, agitation, insomnia. Again, that will be present even after washout. Mental confusion even after washout, hyperreflexia, and basically why mescaline is added to pentylone is a bit on the sharp side effect. So mescaline is added to smoothen the smart effect. So that's it. In summary, basically, what you should be expecting is there will be more cases of NPS abuse among drug addicts that goes into ED. You should see it to top to the maximum by 2028, 20 in about 3 to 4 years time. The effect will be very exaggerated. We do not have much information on its toxic dose, but our initial report from our overseas counterpart and the ones that are done locally would indicate that the effect dose and toxic dose is quite close. So the therapeutic index is quite quite small, and so you should be careful, as you might see death due to overdose due to NPS. With that, thank you very much and have a good day.
Thank you so much, Prof. Madya, Dr. Khairul, for your input. Our second topic for today's webinar is entitled Anesthesia on the Street, Intermediate and Capote Vaping. The session will be delivered by Dr. Yaoi Zhu, who obtained her PhD in Analytical Chemistry from National University of Singapore. She is currently Senior Consultant Forensic Scientist and Division Director of the Analytical Toxicology Division at the Health Science Authority, where she oversees both the clinical and forensic toxicology laboratory as well as the drug abuse testing laboratory. With 3 decades of experience in analytical toxicology, Dr. Yao is deeply involved in casework review and frequently provide expert interpretative opinion in both clinical and also forensic contexts. Dr. Yao is a certified fellow of the American Board of Forensic Toxicology since 2012, has held leadership role in the Asian Forensic Science Network, and currently contributes to the International Association of Forensic Toxicologists. She also has authorized or co-authored 33 publications and 72 presentations on clinical and forensic toxicology as well as analytical chemistry. Without further ado, Dr. Yao, the floor is yours.
Thank you for the kind introduction. Can you hear me well?
Yes.
Okay. So my name is Yi Zhu. I'll be sharing on the recent drug trends in Singapore, particularly on etomidate and K-pod vaping. So etomidate is prescription only. It is available as an intravenous solution. It's used mainly for the induction of general anesthesia. There are 2 forms of etomidate. The R isomers is the active form, and the S isomer actually has 10 to 20 times lower hypnotic effect. So the pharmaceutical grade should be the R formula. Pharmacologically, it binds to the GABA type A receptor and enhances the effects of GABA. Hence, it results in marked reduction in neuroactivity, manifesting as sedation, hypnosis, and anesthesia, which is the desirable effect during anesthesia. It has also minimum impact on cardiovascular and respiratory system compared to other anesthetic agents. That's why it makes it a preferred choice for patients with a cardiovascular compromise because of its hemodynamic stability. In terms of action, is quite rapid. Within the 1 minute of IV, it can induce the unconsciousness already, but it also goes off very fast. It has short duration, 5 to 10 minutes after a single bolus though, due to its high lipid distribution, solubility, and it rapidly distributes from the CNS to the peripheral tissues. Abusers use it actually for the detachment, euphoric, and calming effect. As a pharmaceutical grade of abuse, it is, I think, most commonly abused in Korea. So it's used in the form of ampoules, probably used mainly by medical practitioner. It is also used as a replacement for Propofol, which was initially abused in Korea, but that was controlled under the Narcotic Control Act in February 2011. So since then, there is increasing activities of illegal distribution and misuse, and hence etomidate was regulated. Under regulations on the destination of drugs that may cause concerns of misuse or abuse, ruled in June 2020. This act is actually less stringent than the Narcotic Control Act. So you can see here in the news, reported in July 25, actually, administration or abuse of etomidate, you still need some medical doctors to actually administer for you. And the other forms of abuse starts to emerge during COVID time. In China, because July 21, China has a class-wide ban on synthetic cannabinoids. Basically, they banned up to 500 MPSs in July, and hence the abusers divert and start using something, and etomidate is one of the choices. Initially, it was added as a powder into the cigarette. and smoked. But I think a more convenient way is actually to add into the vapes. So it is known as smoke powder or yanfen in China. In many states and provinces in China start to see this abuse, and it has been associated with a lot of public safety issues, such as dangerous driving, rape of victims that are under the influence of etomidate, self-harm, drowning. So in October, well, just 2 years ago, around the same date, etomidate was controlled. So consumption, smuggling, selling, trafficking, manufacturers are all controlled. And once this is controlled, as you've seen in MPS trends, other etomidate analogs starts to emerge. So etomidate control in October, when the other starts to emerge, July 24th, China also controlled metomidate, propoxate, and isopropoxate. The difference is in this branch group here. Ethyl group, methyl group, isopropyl group, propyl and isopropyl group. So metomidate and propoxate, these are actually not new drugs. They are discovered by Janssen Pharmaceuticals in the 1960s, and it is used as in veterinary medicine. Okay. Isopropoxate probably is something that is synthesized to evade the law again, but it was controlled. And after this was controlled, other etomidate analogs starts to emerge. So about 1 year later, China also controlled another additional 7 etomidate analogs. So you can see that the emergence is similar to MPS. They start to add halogens into the group. That increases the alkyl branches. So you have butyl now, the butyl isomers. And you could have halogens added to the phenyl ring and also some other halogens and nitrates. So 7 others was controlled. So when China controlled in etomidate in October 2023, where does the market goes to? It goes to the neighboring countries. So Hong Kong starts to see it also in late 2020. And it is called space oil in Hong Kong because the people who abuse it looks very spaced out, okay? And seizures and use of this increased significantly in 2024. So this chart shows that the number of people using space oil of concern is that aged less than 21 are actually 3 times more than those above 21. And etomidate becomes one of their 3rd most abused drugs among these younger groups after cannabis and cocaine. So Hong Kong in February 25 also controlled the individual listing, the etomidate plus the 3 analogs. And with China controlling the 7 more etomidate analog, Hong Kong decided that they should control it under generic paragraph. So they have this act that says any compounds that is structurally derived from etomidate by the substitution on this ring on the red circle line, and also any substitution on the benzene ring will be controlled. In Taiwan, it is controlled as a class 3 narcotics in June 24. It is called zombie vape in Taiwan. And in November, just a few months later, it was moved up to class 2, which is of a higher class. And at the same time, they also add in metomidate and isopropex. A few months later, in July 25, they added more, similar, following the trends of China and Hong Kong. And all this is also because of serious social events such as hit and run that kills actually 2 police officers. That's why explains enhanced control. UNODC also highlighted in March 25 that etomidate is drugs of concern because of the increasing detection of intermediates in a lot of other countries. Besides this, East Asia, New Zealand also issued notification about they also started to see vapes containing intermediate in February 25. E-liquids are also found in Cambodia, Indonesia, Malaysia, Thailand, and there's huge seizures also in these countries. You would think that intermediate in the form of a vape is actually easier to abuse rather than having the doctors to inject for you. So actually, there are activities, illegal activities that is going into Korea also with drug-laced intermediate, intermediate-laced e-cigarettes that are going to Korea. So Malaysia and Korea cooperated and actually apprehended a drug ring to smuggle 2 million doses of intermediate laced and also cocaine laced e-cigarettes to Korea. What about Western countries? Intermediate abuse in UK, there is a UK drug checking services. During this period, Jan to June 23, they have reported tablets or crystallines that are actually intended as a sale for as oxycodone or aprazolam Xanax or etazolam. But on analysis, what they get is actually intermediate in the white crystalline form for oral consumption. And the reported effect by the user, it gives you the relaxed effect. There are also reports of a sale of intended oxycodone, but found containing intermediate, plus a synthetic opioid, protonidazole, which is very potent, and just a few low dose, it actually is enough to kill. So you really don't know what you are getting off the streets. What about Singapore? We have been detecting, analyzing vapes that was seized by our Narcotic Bureau, Central Narcotic Bureau, since 2015. And this data is from our HSA illicit drugs lab. Initially in vapes, what we found is usually cannabis, mostly ketamine, sometimes with methamphetamines. And 2020, we start to see MPSs being added into the vapes. And in recent years, 24 onwards, 60% of them actually, more than 60% of them actually contains intermediate. And vaping itself is illegal in Singapore since 2018. And we call it K-pop in Singapore, but it does not contain K as in ketamine. If it does contain, it is actually very rare and only present at trace level. Intermediate is still the same, the biggest component in these vapes. It is called K-pops, probably because it mimics the effect of ketamine. And whether do we detect other analogs? We do detect methylmediates, isoproposates in vapes, and propoxate also in urine, but these are usually present at a much, much lower amount. Probably, likely could be some contaminations of the manufacturing, but we have yet to see intermediate analogs as the main components. The rest of the analogs we have not detected in Singapore. And these are the data that is from our HSA drugs abuse testing laboratory. They test for urines submitted by the narcotic bureaus for controlled drugs. Although intermediate was not controlled, but we were monitoring it because of the trend seen in East Asia. So since October 24, when we added into our screening panel, we start to see an increase in the number of intermediate positive urine samples. And most of this still contains methamphetamine concurrently, about 46%, and meth is one of the highest abused drugs in Singapore. There are intermediates as co-detected with ketamine or THC or heroin. This data is from the HSA Clinical and Forensic Toxicology Lab, which we received antemortem and postmortem toxicology samples from hospitals and the mortuary, typically for intoxications cases or suspected poisoning cases. So this data was collected since January 24 to August 25. We exclude cases where intermediate was medically administered or medical intervention was suspected prior to sample collections. We include cases where there is documented use of vapes, K-pops, or relevant clinical presentations noted in the case histories. And also in recent 25 onwards, we included intermediate acid. So this data is you can call it intermediate consumption cases where intermediate acid was also detected. So you can see that there is an increase in the number of positive detection. About 18% of them were postmortem cases, and about 40% has other control drugs or other substance of abuse, such as cough syrups and EPAM, which is nitrazepam. In terms of demographic from the abuse cases, we compare it against the arrested control drug abusers. By gender, excuse me, it is similar to arrested CD abusers, but you do have a higher proportions of female abusers. In terms of ethnic groups, the arrested CD abusers have lesser Chinese, but in the intermediate abusers, the proportions of Chinese, Malay, Indian, and others actually mirrors closely to that of Singapore population. In terms of age, of concern is that the number of K-pop users aged below 20 is actually 7 times compared to those arrested control drug abusers. And the youngest was 13 years old. And this is a concern because intermediate, the use of vapes is actually easy for the youngsters. Not much skills required, probably not much courage required because you just have to smoke. So it is a concern because these youngsters, if they start with intermediate, they will likely progress slowly to gradually to the hardcore drugs of abuse. We compare the antemortem and postmortem blood intermediate levels. The median for antemortem is about 0.037 with the mean close to 0.04. The range is upper limit is 0.26. 0.02 is our limit of quantitation. For the postmortem cases, the median and mean is higher and with upper limit of 0.31 microgram per ml. If you to compare that with a single IV bolus dose of 0.22 milligram per kg given, which is a typical dose, to surgical patients, the intermediate average plasma levels were initially a high of 1.1 microgram per ml, but it degrades faster, it metabolizes very fast. Within 2 hours, it has dropped to 0.03 microgram per ml. So this shows that the abuser's intermediate actually is much higher than the dose that is given under the IV condition. The postmortem cases, 41% of them are actually fell from height, 38% were found dead or sudden death, and 14% were involved in road traffic accidents. Intermediate may or may not play a contributing cause to the cases. Some of the road traffic cases also contains ethanol, methamphetamines, and MDMA. So it could be contributory. But you can see that the fell from height cases, the ranges are higher compared to the rest of the different cause of death. And for DUI, driving under the influence, these are for living patients. The levels are comparable, although in living patients, it may be slightly higher, but it's the means are quite comparable. So reported cases, the studies actually shows that intermediate inhalation can induce psychiatric symptoms, such as depressed mood swings, aggressive, and increased impulsivity, leading to suicide attempts. And on social media, there are a few videos by mothers whose son or daughter are actually abusing intermediates. And this, you can Google this. The house actually contains a CCTV. So this is from their in-house CCTV. Whenever the son smokes K-pop, he will be aggressive, and a lot of time he wants to jump from the window. The mother has to actually stop him. So the adverse effect of intermediate, the knowledge about the pharmacology of inhaled intermediate is limited. Most of it is used IV, but there's very little studies about how the inhalation, the pharmacology of the inhalation is. But definitely inhalation will involve higher doses and prolonged use, because according to these abusers, they can smoke up to 1 to 3 capsules a day, and usually they will smoke non-stop. Smoke, they fall asleep, when they wake up, they smoke again. So there is prolonged use. So the reported effects in literatures and on social medias includes decreased altered consciousness, slow response, dizziness, drowsiness, confusion. Nausea and vomiting is a known effect of intermediate. They also exhibit emotional instability, altered mental status, unsteady gaits, tremors, slurred speech. You can see on social medias when people vape K-pop, you can see them falling off the road, can't walk properly, and usually they have less minimum control of their own body. It also causes adrenal insufficiency and hypokalemia. In overdose cases, respiratory suppressions or bradycardia may also appear developed. The intermediate adrenal depression effect mainly branches from the fact that it inhibits the 11-beta hydrolysase, which is a critical enzyme in the adrenal cortex responsible for the final step in the cortisol and aldosterone synthesis. So intermediate actually decreases the cortisol production, and this affects stress response, metabolism, and immune system. It also reduces aldosterone synthesis, and this will affect the sodium-potassium balance and also blood pressure. Hence, the common adverse effect of this adrenal insufficiency, you can see actually clinically tested using hypokalemia, hypoandrogenism, low cortisol levels. So in Singapore, when the situations get worse in starting around mid-25, we are looking closely at the trends. And in July, the Minister of Health, together actually with Minister of Home Affairs, announced that intermediate will be classified under Class C controlled drugs in the Misuse of Drugs Act. Before that, intermediate is only controlled in Poisons Act, similar to Malaysia. It is only about the sales of a drug, pharmaceutical drugs. And the act itself is not meant to control abusers. So the act is has lesser penalty. By moving it into the Misuse of Drug Act, we will have more stronger deterrence towards the abusing. So before that, in July, publics are actually advised to bin their vapes, and also if they need support for quitting, they can actually volunteer themselves for rehab. Which is why we see from the graph previously that there's a huge jump in July and August, is because a number of them actually went to the Institute of Mental Health for rehabilitation, and urines were sent in first to assess their conditions. So from 1st September, actually etomidate together with 7 other analogs were listed as a Class C controlled drug in the Misuse of Drug Act. So the penalties, the first for e-vaporizers means it's purely nicotine vapes, which is also not allowed in Singapore. It has a penalty of fine for etomidate e-vaporizers. Besides the fine, there's also a 6 months rehabilitation. Okay, so this is not mandatory. You have to go to seek rehab in hospitals or social care agencies. But if you're caught second time, it becomes a mandatory supervisions, and you will include drug testing and rehabilitation for 6 months. And when it is third time, there will be detention into the drug rehab center. Mandatory rehab plus drug testing and supervision. Okay, next we come to metabolisms of etomidate and the analysis. So in 2025, this paper was published. Etomidate metabolism was studied using zebrafish, human liver macrosomes, and S9 fractions, and analyzed by quadruples or orbitract LC-MS. So up to 14 metabolites were detected in this study. We shall concentrate on this particular, the right-hand corner. Okay, so etomidate actually, the ester group can be easily hydrolyzed, and it breaks down to etomidate acid, which furthers glucuronide to form glucurinated to form the glucuronide. Etomidate itself also forms a glucuronide form. And an earlier study, less than 2% of etomidate is excreted as free drug in urine. Etomidate acid is the major metabolite and accounts for about 80% of the urinary excretion. The ester bond actually hydrolyzes by the liver esterase easily. So whether it is metomidate when the R is a methyl group, or ethyl group etomidate, or a propyl group, all this will break down to the etomidate acid, which is inactive. So the ability to detect etomidate acid helps to extend the detection window of etomidate and its analogs. So you can detect a consumption for a longer period of time. Currently, there's very little study about how long after vaping will etomidate still be detected in the urine. So we are lacking of that study at the moment. Analysis of etomidate acid, according to this paper, which do a review of the methods, most laboratory uses LC-MS, or some use GC-MS with liquid extractions in both blood and urine. The limit of detection, depending on the techniques, can range from about 0.01 nanogram up to 20 nanogram. For our laboratory, the clinical and forensic toxicology lab, we uses high-res LC-MS for the analysis. The sample prep is using supported liquid extraction for basic drug panels. And for all other panels, we use protein lipid depletions. Protein lipid depletions actually just remove the protein, so it is not pH dependent. It allows us to detect a wider panel of drugs. The instruments, the Q12MS is used for the basic drug panel, and the Orbitrap MS is used for the acidic and neutral, and sometimes the basic drug panel. This approach using high-res MS actually allows us to do retrospective analysis in the event that a new drug has emerged before we have included it into our library. It also facilitates the ease of adding new analytes into the library. For urine, similarly, we use liquid-liquid extraction under both basic and acidic pH. We also perform enzymatic hydrolysis to increase the detection of intermediate and intermediate acids. So our study of some unhydrolyzed and hydrolyzed urine can show actually it can differ by about 20 to 100 times difference. If you don't hydrolyze it, you might miss the intermediate. But after hydrolysis, the amount can jump from, we have one case that actually the amount jumps from 5 nanogram to 400 nanogram. So strongly advise that if you're doing intermediate, do consider enzymatic hydrolysis. An instrument that we use is ion-trapped MS. This Bruker ion-trapped MS, and it allows us to do basic acidic neutral panel. Again, it also it doesn't allow retrospective analysis, but it allows easy addition of new compounds into the method. This will show some intermediate Q12 MS chromatograms. Intermediate and intermediate elutes earlier, we are using a biphenyl column. The spectrums look similar. The masses, of course, is different, 245 for intermediate and 231 for intermediate, but the fragments are very similar. Both have 95 and 105. Okay. For propoxate and isopropoxate, we resolved it, and you can see that the fragments also look similar compared to that of intermediate and intermediate. Both have 95 and 105. And the separation is about 0.3 minutes. So we also analyze the intermediate present in K-pot in one of the studies, which 16 intermediate vapes were analyzed from May to July, and this work is done by our HSA pharmaceutical division. So in each vape liquids, which looks like, the pop looks like this, the vape liquids is about 1.3 to 2.1 mil, average is about 1.6 mil. The intermediate concentration is about 122 to 169 milligram per mil. And that will mean that each pop has about 120 to 293 milligram per pot. If you compare that to intermediate IV solutions, which is 20 milligrams per 10 ml or 2 milligrams per ml, the product inserts for such MPU says that you do not exceed a total dose of 60 milligrams. And abusers can easily finish entire pop in one day. So the amount they are taking is 5 times more. And I have come across papers that also says that those chronic users can use up to 10 pops. But this study was in China, and we are not too sure what is the concentration in each of their pops. So how you differentiate a normal vape with intermediate lace K-pop? A normal vape usually presents itself as a legitimate vape with manufacturer's brands. It can come in as a non-disposable pots or disposable pots with disposable vapes with detachable pots. Okay. For K-pops or vape juice that is mixed with intermediate, usually it comes as detachable ones where the pops can be refilled and reused. And usually there's a barcode or engravement on this end part of the pop. And when the chemicals were analyzed in the normal vape, usually it contains glycerols or glycerine and propylene glycol, of course, nicotine, with a lot more Menthol and flavoring chemicals. So it comes in all kinds of flavor. Watermelon, strawberry, vanilla, anything. For intermediate lace K-pops, usually the compositions is simpler. It's intermediate plus glycerol, glycerin, that's all. And sometimes we do see traces of intermediate, and as shown in the previous graph, sometimes as propoxates also. So that comes to my end of the presentation. The take-home message for medical doctors: you need to understand or recognize the symptoms of intermediate abuse. And clinical diagnosis, adrenal suppressions, hypokalemias could be one indication of possible intermediate use, of course, besides the clinical histories. And for the laboratories, strongly advise that you should test for intermediate acids and you should hydrolyze your sample. So with that, that ends my presentation. Thank you for your attention.
Thank you very much, Dr. Yao, for your insightful sharing. We trust that everyone has gained valuable knowledge from it. We will now take a break. We will break until 10 a.m. Okay. Welcome back, everyone. I hope everyone is well rested. So we shall resume our webinar with our last topic for today, which is antipsychotic medication, will be presented by Dr. Hartadi Tanjoyo. A little bit background about Dr. Hartadi. Dr. Hartadi is an emergency physician working at Dr. Saiful Anwar General Hospital. He obtained his master in emergency medicine in year of 2024 with the thesis entitled Agreement between Plain Photograph and Ultrasonography in assessing chest trauma based on thoracic trauma severity score in patient in the ER of Dr. Saiful Anwar Hospital. And also he obtained his medical doctor degree also from Universitas of Brawijaya in the year of 2014. Without further ado, I would like to invite Dr. Hartadi to deliver his lecture.
Yes, thank you, Farhana. Good morning to all panelists and audience. Yes, good morning, all. Yeah, today I will bring my topic about antipsychotic intoxication, a clinical and overview. We are focusing on the serotonin syndrome and neuroleptic malignant syndrome. As we know, antipsychotic medication have revolution and more developed in the last year worldwide. We have followed the trend. Before, we know the trend for oncologist medicine, and then anti-allergic and immunologist medicine, and now neurologic medicine and also antipsychotic medicine. So yeah, I think this drugs will be more common in the next few years. Okay, as introduction, yeah, we know antipsychotics is primarily used to treat schizophrenia, manic phases, or bipolar disorder and agitated behavior. We know also psychotropic drugs, including antipsychotics, are significantly used in suicide attempts, which are frequent methods of suicide worldwide. Yeah, this is the prevalence in the United States is quite high, but in our hospital we already collected data from the last year 2024. We only have about 36 patients that years. Most of them, or 36%, is from drug intoxication. Yeah, we can see here from 36 patients with intoxication, we have 13 patients with drug intoxication. which half of them is antipsychotic, about 46%. Antipsychotic that used in the toxicity is escitalopram, sertraline, quetiapine, haloperidol, and also clozapine. As we know, in this list, the antipsychotic usually combined with antidepressant like sertraline or sertraline, and the antipsychotics we have first generation like haloperidol, and also second generation or atypical like quetiapine. Maybe you should know that in Indonesia, especially in Malang. Malang is a small city. Yeah, we have not much case about toxicity or maybe addiction or maybe or drug abuse. Yeah, we have a few of that. And this is for about antipsychotics. Yeah, what are the antipsychotics? Antipsychotic is a class medication used to manage psychosis. Yeah, example schizophrenia or bipolar disorder. Yeah, they are divided into two main categories. First generation antipsychotic that primarily block dopamine 2 receptors only, and the second generation or atypical, they can block both dopamine and serotonin receptor. This is the list. First generation antipsychotic is chlorpromazine, haloperidol, trifluoroperazine that is common in our country. And the atypical or second generation antipsychotic is aripiprazole, clozapine, olanzapine, quetiapine, risperidone. The danger of intoxication. The antipsychotic intoxication can occur due to the overdose, drug interaction, or individual sensitivity. We should remember that two of the most serious and life-threatening complications are serotonin syndrome or neuroleptic malignant syndrome, yeah, which is often mentioned in our books, Emergency Medicine. So how we differentiate between serotonin syndrome or neuroleptic malignant syndrome, we will discuss later in this topic. As in general antipsychotic overdose, we should remember that the effect, even they are serotonin or they are neuroleptic malignant, they will have effect on CNS, depression. It will be manifest sedation and coma, and the second cardiovascular effect, it will manifest as hypotension, tachycardia, and as also extrapyramidal syndrome, which is dystonia and Parkinsonism-like gesture. This is only reminding that the second generation antipsychotic or atypical antipsychotic, they have both effect on the dopamine and also the serotonin receptor. So usually the dopamine receptor is related to neuroleptic malignant syndrome, and the serotonin receptor is related to serotonin syndrome. So the blockage of both of the receptor will be could be manifest between serotonin or NMS or neuroleptic. Beside the dopamine and serotonin, there are also other receptor like histamine. So they may cause drowsiness or decrease of consciousness, and also muscarinic. And they can manifest in sedation, sinus tachycardia, and urinary retention. Okay, this is the pathophysiology of serotonin syndrome and neuroleptic malignant syndrome, or NMS. Maybe I will use NMS yeah, for neuroleptic malignant syndrome. The most important is, when is the onset? The onset of serotonin syndrome is usually very abrupt, very fast. Usually they consume some pills or many pills that cause serotonin syndrome. But in the neurologic malignant syndrome, it will be more malignant, as we say the name malignant. Malignant means it will appear more severe than serotonin syndrome, and also malignant meaning that the process is very slow. It has a progression. And in serotonin syndrome, we know the effect is because excess of serotonin activity because of that drugs. And the neuroleptic malignant syndrome, the effect is caused by sudden and severe reduction of dopamine activity. Usually, it's not that sudden, but it has a process, yeah. Maybe some days or some weeks, yeah, depend on the patient or how about the comorbids or risk factors. And first, we will discuss about serotonin syndrome. We know the drugs that might cause serotonin syndrome is SSRI, like citalopram, escitalopram, SNRI, like venlafaxine, MAOI inhibitor, phenylcycline, and also the cyclic antidepressant like amitriptyline, and other agents like dextromethorphan, lithium, tramadol. So basically, there are many drugs that might cause serotonin syndrome. But if you want to remember, the first three is the most important drugs: SSRI, SNRI, and MAOI inhibitors. As you know about the other agents like the cyclic antidepressant, also might cause anticholinergic toxidrome, or maybe the other agents can give toxidrome mimics sympathomimetic toxidrome. So yeah, you should consider the poisoning in other toxidrome also. This is a pharmacologic about serotonin syndrome. Yeah, we know we have serotonin. Serotonin is a substance or neurotransmitter that can or that might make us happy, less depressed. So they are known as an antidepressant. As we know, there are many methods to make serotonin increase in the cleft or in the postsynapse. At first, there are serotonin releasers. More of serotonin releasers means serotonin in the synapse and more effect to make us happy. And the other, there is serotonin inhibitors, or SSRI. They are inhibit the reuptake of serotonin here, so the serotonin may still in the cleft of synapse. And the other is monoamine oxidase inhibitors. The monoamine oxidase inhibitors will inhibit the metabolism of serotonin inside the presynaptic neuron. Yeah, we know that the serotonin toxicity triangle, usually serotonin releaser combined with MAOI inhibitor will cause serotonin toxicity, and usually MAOI inhibitor combined with SSRI will also cause serotonin toxicity. And the last also usually the serotonin releaser combined with SRI maybe do not cause serotonin toxicity, and maybe they may cause serotonin toxicity. It depends on the patient or the risk factors. So we should suspect if there is a case about combination of both of drug. How serotonin syndrome is manifest? Yeah, we may know the serotonin triad. First, altered mental state. Second, neuromuscular excitation, and the last is autonomic symptoms. The symptom is not really specific. IMS like agitation, confusion, delirium, autonomic symptoms like hyperthermia, tachycardia, hypertension. This mimic with anticholinergic or sympathomimetic toxidrome. And the neuromuscular agitation is clonus and hyperexia, tremor, seizure, and rigidity. Maybe sometimes it is hard to differentiate between is it a clonus or is it is it a rigidity or is it a hyperexia with clonus? Yeah, sometimes the patient just rigid. Yeah, we cannot know the border or the definition between the rigidity is cockwheel or pipe and rigidity. So we know the Hunter criteria. Is it the easiest way to make a diagnosis about serotonin syndrome? In the first, we should know that the patient is consumed serotoninergic agent. If the patient consumes serotonergic agent, we search for spontaneous clonus. Is there a clonus? So we may diagnose a patient with serotonin syndrome. But if we do not find the clonus, we can see about ocular clonus. If we see ocular clonus, we see another symptoms like agitation, or diaphoresis, or hypertonia. If two of the criteria met, we can cause serotonin syndrome. We can make diagnosis of serotonin syndrome. And the last, if there is no clonus or no ocular clonus, inducible ocular clonus, we search for tremor and hyperreflexia. If there is hyperreflexia, yeah, we may diagnose the patient as serotonin syndrome. We should remember that the criteria also have sensitivity is not quite high, or 84%, and the specificity is specific as 97%. So we should consider another differential diagnosis when, even though the under criteria is met. From the management, of course, we should discontinue all the serotoninergic agents or drugs. And the second is supportive care like hydration. We give very much fluid eventually. Moreover, if the patient has rhabdomyolysis. The second is external cooling, or maybe we can give the drugs like dantrolene. And the third is benzodiazepine for agitation and muscle relaxation. And if there is hypertension, we give antihypertensive such as nitroprusside or esmolol. And we can give also a vasopressor if there is hypotension. Yeah, maybe there is different type. Sometimes hypertensive and sometimes hypotensive. Maybe they are depends on the another drugs that the patient consume or another risk factor from the patient. Management of serotonin syndrome, yeah, we can give serotonin antagonist is cyproheptadine. Cyproheptadine is basically antihistamine. We can give the bolus of bigger dose like 12 milligrams and repeat dose of 2 milligrams every 2 hours until clinical improvement. And the prognosis is usually resolved within 24 hours after the inciting drug is stopped. With an exception, if fluoxetine is used, usually the half-life is very long and it will be more than 24 hours. And the second of antipsychotic drug effect is neuroleptic malignant syndrome or NMS. NMS is similar with SSRI usually, but this NMS will manifest longer than SSRI. Usually they are not result of an overdose, so they are result of accumulated dose. Maybe the dose is within the therapeutic dose, but the patient consume the drugs is for a very long time or for a few weeks. NMS can be manifest from that. Usually, the drug that causes NMS is haloperidol or first generation antipsychotic. But atypical antipsychotic also can cause NMS. Many atypical link have occurred with clozapine, which is notable given its low incidence of extrapyramidal symptoms. Medication associated with NMS, like usually there are some risk factors. First, rapid dose escalation, and the second, parenteral or injectable administration. The third is dehydration, and the last is concomitant use of anticholinergic. This is the diagram how NMS can be caused. Of course, the first is there is antipsychotic use, and then dopamine dysregulation. We remember that the dopamine is need for happiness also, like serotonin, but in psychosis, the dopamine is blocked by the drugs or antipsychotic drugs. The blockage of dopamine may cause muscle rigidity, impaired head regulation, and also altered mental sensorium. It's quite similar to serotonin syndrome. The symptom, yeah, is quite similar. Altered mental state, hyperthermia is same. This I mentioned like severe lid pipe muscle rigidity, but in serotonin syndrome also have rigidity. But we can really difference between a lid pipe or another rigidity in the clinical. And the last is autonomic instability, can fluctuating blood pressure, tachycardia, and also diaphoresis. For diagnosis of NMS, usually based on characteristic symptom in the context or neuroleptic use. Because the landmark of NMS is the rigidity, we may find elevate of creatine kinase from the muscle breakdown. They will be increased at least 4 times upper limit normal. And management, at first, yeah, we can treat the agitation with lorazepam or dexmedetomidine, ketamine. We reduce the core temperature with cooling system, maybe fan, maybe SPEX, cool saline, and paracetamol or acetaminophen. We should discontinue the drugs, implicated drugs like antipsychotic usually. And then we manage fluid balance, manage blood pressure with clonidine or clofidipine. We treat the muscle rigidity with muscle relaxant, same with agitation. So the benzodiazepine can benefit to treat muscle rigidity and also agitation, and manage airway and respiration as needed. Maybe we should give ventilator support in some patients. And the last, initiate preventative measures like skin and eye care, proton pump inhibitor, or maybe MWH. This is the difference, yeah. Maybe if I can suggest the most important is precipitant, serotonin. The onset serotonin syndrome is abrupt and neuroleptic is gradual. Maybe the patient has relapsing symptoms. Sometimes the patient looks good and sometimes looks sick. But in the serotonin, they look fairly abrupt. Suddenly, the onset is very sudden. The vital sign is almost the same. The skin is also the same. And the resolve, the abrupt onset is related with abrupt or rapid resolving for the serotonic agents. Yeah, and the muscle tone is quite similar, I think. Reflex, maybe from the reflex we can differentiate for between serotonic and NMS. We should remember hyperreflexia or conus is a landmark of serotonin syndrome. The pupil It could be mydriasis, yeah, and the others is normal, and bowel cell hyperactive, and the other is decreased or normal. And the last, from my presentation, I will present our case. 22 years old female patient feel her heart beating very fast, and she has cold sweats on her hands, experience tremors after taking olanzapine, clobazam, sertraline, and riduzole, 3 pills of each. Her GCS is 356, blood pressure is 116/60, heart rate is 120 beats per minute, respiratory rate is 20 beats per minute, and temperature is 37.7 Celsius degree, and the last saturation is 98%. This is in this picture I will show about the hyperreflexia. Yeah, even though it's not a clonus, it's a hyperreflexia. The reflex is +3, and the others is the eye clonus. It's like a ping pong ball in the eye. It's quite similar with nystagmus, but the direction is different with nystagmus. Nystagmus usually have a unidirection or bidirection. There is a trajectory in the nystagmus, but there is no trajectory in iclonus. It's like that. And the last key takeaways and conclusion, yeah, antipsychotic overdose is common, usually intentional, because we know the patient has depression usually, and also schizophrenia. It is high likely they have a will to suicide, so they use their drugs to end their life. And then NMS and serotonin syndrome are critical life-threatening toxic syndrome that must be recognized promptly. Differentiating them relies on clinical history and specific neuromuscular findings. Supportive care is paramount. Management focus on airway protection, hemodynamic support, and treating complications like seizure and hyperthermia is important. We should remember the ABC first, and we treat for the specific syndrome. Either it is an serotonin syndrome or NMS. Always obtain an ECG monitor for QT prolongation and another conduction. As we know, some drugs, usually like tricyclic antidepressant, or they might cause QT prolongation. I'm sorry, they may cause QT prolongation, and also maybe they may cause natrium blockade, so QRS also prolonged. Okay, and that's all. Thank you for the time, and I will give the time for you, Farhana. Thank you.
Okay, thank you, Dr. Hatari, for your input on the topic of antipsychotic drug. I would like to invite all the speakers now as we are starting our Q&A session. And for this session, I will read up all the questions in the Q&A box, and the respected speakers will answer the question from the floor. Okay, we shall begin with our first question from the chat box. This question is from Miss Chim. Question is for Prof. Madhya, Dr. Khairul. Prof, with the increasing trend of NPS, how can frontline emergency physicians adapt their diagnostic and management approaches when conventional toxicology screening often miss these agents?
Okay, thank you. I think this refers also to the second question, correct?
Yes, yes.
Yes, all right. Also,
the second question, given the rapid emergence of new chemical structures in NPS, how can forensic lab in Malaysia keep pace with the detection and classification?
right. So I'm going to try to answer both questions at one single go. Basically, the the project that I'm doing and in which we have turned into a service is actually a 3-phase project, which involve Ministry, which involve PDRM, KKM, Ministry of Health, and Customs, and a few other minor agencies. So what will will be what will be occurring is that our lab will be identifying new compounds that will be coming up, and specific drug labs under KKM or Ministry of Home Affairs will be given a special equipment that will be able to identify the compound. So it's so what you do is, if there is a case at ED, or if you can get the urine or you can get the serum, you just pass it to the lab, and the lab is able to provide you with the possible compound within 30 seconds. So we have already run the test run, and the results were very good using the new system, and the new system integrates well with our lab. So we tend to go into phase 2, which would cover firstly drug labs, which are under the police, and then eventually would cover KKM in the near future, which is at phase 3. So hopefully, each lab will, each hospital will probably have the machine online, and we are able to update the thing overnight with new compounds. And so what you need is just to pass the sample to the drug lab, and should get the result within 30 seconds. So the machine is able to identify average about 600 compounds at once within the 30-second window. Thank you.
Okay, thank you, Prof. The next question. The next question is for Dr. Yao. Dr. Yao, since you mentioned that intermediate can be detected in urine, is this drug included in the routine toxicology screening panels performed in most emergency departments in Singapore, or does it require special request or advanced testing?
Okay. Can you hear me?
Can.
Yes, okay. Yes, this is intermediate, and intermediate acid is part of the routine comprehensive test. So we will detect it in every cases if the comprehensive test is requested. No necessary to actually request for a special test.
The next question, given the rise of street-level access to potent anesthetic, what early red flag sign and symptoms should ED clinician recognize to differentiate them from other causes of altered mental status? I believe this is for Dr. Yao also.
Okay, and okay, for this one, I have to qualify myself. I'm not a medical doctor. I don't work in the ED, so I may not be able to give you the best advice on this. What we see from case histories provided to us is that those intermediate vapors, because they tend to have lesser control of their bodies and movements, they tend to fall. So one of the symptoms that actually is constantly indicated is that they tend to have bruises and scars on themselves. And of course, adrenal inefficiency or the biochemistry test may be able to tell whether this is likely linked to an intermediate use. Also, there is currently actually test kits that is produced by China that can test for intermediate at 2050 nanogram per ml. So such test kits can be used as point of care diagnostic to screen out whether these are possible intermediate use. Yes. And of course, if you can get the histories from the person, that's good. But if it's in coma, then I guess I leave it to the medical doctors to have their best assessments of the case. But a profiling of the typical profilings, like what I shared, but that's pertaining to Singapore population, might give you some idea whether this person could or could not be a intermediate abuser.
Yes, yes. Regarding the adrenal suppression, how significant is the risk when abused recreationally, and what are the implications in acute care setting?
Okay, again, according to literature, from China, Hong Kong, adrenal suppression seems to be a very common effect of intermediate abuse, especially for chronic users. Under the IV conditions, although the adrenal suppressions can be reversed within 6 to 8 hours, continuous infusion or continuous inhalation might drag on that time, probably to more than 24 hours. So, how significant is this risk? So basically, it is quite one of the common side effects. And one of the question is asking whether in hospital setting, they are using intermediate for rapid sequence intubation, and whether this misuse in the community will actually complicate this use. There are literature supporting that to move away from intermediate use if, let's say, this becomes one of the common abuse in the community. I think I cannot vouch for the hospitals, but not many of our hospitals locally are using intermediate. They have moved to ketamines and propofol and other anesthetic if necessary. Yeah.
The next question is for Dr. Hart, Prof. Khairul. Is from Muhammad Rusti. Is there detected case referred to you that related with illicit drug laced with psilocybin and its metabolite? And what is prevalent among received sample? And how about cases related to vape?
Okay. There were no cases of psilocybin sent to our lab, but we do have report from our partner lab in Jabatan Kimia, Malaysia. There was about, if I'm not mistaken, there's a case in April of case of psilocybin. There are cases based on the intelligence report. We understand that cases of psilocybin is increasing. It's in an uptrend. But again, as I can't comment in detail because some of the information is restricted. But there are positive results of psilocybin. It doesn't come from our lab. It comes from our partner lab, which is at Jabatan Kimia, Malaysia. And that's as much I can tell you. What about cases related to vape? Right. In vape, it's messy. There's a lot of cases there. My lab handles urine and wastewater because ours is close monitoring. But we will be expanding to cover vape. We just received instruction by Ministry of Home Affairs to expand it to vape. And from what I understand, we'll be doing it starting next month. Hopefully, the issue of vape will go down when Malaysia starts following Singapore in banning vape. That will really help us a lot. Yes, thank you.
The next question goes to Dr. Hartadi. Polypharmacy is common among psychiatric patients. How can we balance rapid stabilization with avoiding drug interaction when treating suspected antipsychotic overdose?
Yes, thank you for the question. I think actually in our hospital we do not have a facility like a tox screen, and we usually manage the patient without knowing what is the agent that the patient consume. So we often prioritize. We should prioritize between A and B and C first. We focus to stabilize the airway, breathing, circulation, without giving the specific treatment for the drugs. So if you ask me how to avoid drug interaction, maybe we should search for another proof that may cause the patient, specifically for the toxicity of the patient. Maybe if the patient has like widening TRS, maybe we should give like sodium bicarbonate for the patient. And if the patient has like a low blood pressure, we should give the fluid first. While we also thinking, is it appropriate or not to give the vasopressor for the patient? Yeah, if we already elaborate the drug that patient consume and the effect of the polypharmacy, we must know what is the effect of the drug that the patient consume, right? So we might start from the point and then give the treatment according to the patient history. I think that is the best. And the second, maybe if you are afraid to give too many drugs that may complicate the patient, maybe you should remember that benzodiazepine is a primary choice for the most intoxication, right? They are very useful, benzodiazepine, and very ready in our ER. We can give benzodiazepine first. Moreover, if your patient has hypertension, tachycardia, and the other symptoms, I hope that I can give the appropriate answer.
The next question is to Dr. Hartadi. What are the key ECG findings that should alert us in ED to life-threatening antipsychotic toxicity, especially in setting with limited lab resources?
Yeah, it's like the question before. The ECG findings usually we should arise. Alert is first KRS widening. That may be a sign of natrium blockage. So we can give sodium bicarbonate for that. And the others is like QT prolongation, as I mentioned in point before. Yeah. If there is a setting like a QT prolongation, maybe we can give calcium gluconate. It might stabilize the ion channel. But yeah, I think it's depend on the case by case. Yes, thank you.
And the last question is, to Dr. Hartadi, since serotonin syndrome usually resolve within 24 hours, when it is indicated to start cyproheptadine, in example, what sign or symptom to look for?
For the truth, actually, in our hospital do not have cyproheptadine. As we know, cyproheptadine is ready in Indonesia as a tablet, but we do not provide it in our hospital. So basically, the serotonin syndrome is treated by supportive measures like benzodiazepines. As we know, also the patient we reported before, it consume benzodiazepine about three pills, and also the serotonin agent about 3 pills, and other psychotic agent about 3 pills. Yeah, we have a hypothesis that the symptom for the patient is relieved by itself. Yeah, because the patient also consume the benzodiazepine, so the benzodiazepine can buffer the toxic effect of another drugs.
Okay, last one, Dr. Hartadi, it's from my personal question. Since just now you mentioned Malang is a small city, do
Yes.
you want to share your own personal experience managing any interest toxicology case there?
I'm sorry, managing what? Managing?
Since just now you mentioned about Malang is a small city, do you mind to share your own experience about any interesting cases in your hospital? Any cases you encounter before to share with all the participants?
Yeah, maybe compared to Jakarta, Jakarta is very big city with uh with higher lifestyle there than in Malang, yeah. So I think Jakarta may consume more alcohol or more abuse in psychoactive drugs, like Prof. Khairul Osman mentioned before. But in Malang is a small city, and we do not like to consume alcohol or take another drugs for recreation, especially. So from that, yeah, I already encountered. I still encounter some cases like usually for uh, parole or what can we say uh, 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 the people in the prison, yeah, the people in the prison, they might buy the drugs illegally, and they still can consume that. So I have met that kind of patient. A guy from the prison came to the ER with unconsciousness and then hypertension, mydriasis pupil. We still suspected as a stroke because it is sudden, so we do CT scan, CT scan normal, and we might treat them as a symptomatic agent, even though we just guess the substance abuse is cocaine like that, but we do not really check the urine or the blood for the tox screen. And after we give benzodiazepine again, the patient is wake up and they confess about the drugs that they take. Maybe kind of like that.
Okay, thank you.
Can I ask a question?
Yes, please.
I'm sorry, but this question is directed to Prof. Karu. Sorry for that. Okay, you mentioned about a test that can get results in 30 seconds. I'm interested to know what kind of machine is that?
I was also going to answer that question after she was finished. I couldn't find it. I saw the question and then disappeared. So
Yeah, I
I
think
was
you probably
looking through the
queued, yeah.
question. Okay, so basically, our lab is running using a Bruker LC-MS-MS timsTOF.
Mm,
All right. So
mhm.
we have created a special system, which then when we identify the compound, it then can be transferred into a special format for Bruker's DAT system.
It's a DAT. Okay.
Yeah, it's a DAT. So if I'm not
Okay.
mistaken, you have a DAT system
We
from
tried out before. Yes.
yeah, a few months ago. I don't know what happened to it. I think you're going to buy it. So that's useful. But when we ran through the DAT, although the supplier assured us it is able to look at 1,000 drugs, it's not able to do that. No, it's not. So the maximum we find is about 500 to 600. So we really need to, and we need to really modify the database so that it's able to do that. So when we do it on the team stuff, we transfer the data to the DAT, but we have a proprietary system script that will do the conversion to ensure a more accurate result, identification.
Okay.
Right.
Okay, and this is done on the neat urine without any treatment.
No treatment.
Okay, impressive.
Right.
Yes. Okay.
Yes.
I just want to raise one point. For those labs that are doing intermediate, as I say, I strongly encourage them to do intermediate acid because the intermediate acids can be present in 100 micrograms per ml. So it is a good indicator, and it has probably a longer half-life than intermediate. So it's a good indicator for consumption profiling.
Okay, thank you very much to all the panels.
There is a question. One more question.
Oh, okay, sorry.
Oh,
Oh, Dr. Yaus.
Oh.
Yeah, this is from Owen. Greetings to Dr. Yao. It has been an ongoing battle to tackle the street intermediate abuse in Singapore. What has been the biggest challenge thus far that you might be able to share?
Okay. I guess first of all, we have been detecting intermediate since very long time because it is anesthetic. So it coming to the scene does not pose too much of an analysis problem to us. I think the problem lies with all the policy changes. Okay, so in the past month and so we are involved in a lot of policy discussions, how to do this and what best to do it and all those things. That is more administrative and time consuming. In terms of laboratory, I think we have to keep horizon scanning constantly. We have to do it. So we see what's the trends out there. And of course, one good thing is if you do have an illicit lab that you are dealing with or collaborating most of the time, you get most of the information from the illicit drug seizures because that's where they can easily detect high concentrations of the drug in the pure form, or even if it's in a tablet, in a vape, it is still higher concentration than when you compare to blood or urine. So we always collaborated with our illicit drugs lab where we get the information. Once we have the information, even if we don't have the reference standards, we will use the exhibit itself to put into our libraries, at least to open up the window to detect such substances. And if we start to see trends of it coming up, of course, we will purchase the reference standards and start developing method for it. That's why we are using high-res MS because in compared to a LCMS MS method, it is easier to detect anytime and retrospectively. Okay, so I would think that that is our biggest challenge is the administrative changes. With all the administrative changes, your reporting, your workflow all have to tweak. And sometimes in this particular case, it was tweaked in quite a short time of 1 month. So that is the administrative change challenge that we are facing. But I think now it has come down. Everything has stabilized since we implemented in 1st September. So yeah, we'll see how these things evolved. Like any MPS, I think it may evolve to something else.
Thank you, Dr. Yao. Is there any more question from the floor? I think so far we have answered all the question in the Q&A chat box so far. And we shall proceed our webinar session today with our Kahoot session. First question, overdose from new NPS is estimated to increase to year 2023. And 10% or 70%. Okay, time's up. So the correct answer is 70%. 11 people got it right. MDMC first. Second question, methamphetamine are usually formed together with the answer is no other drug. Third question. Scoreboard. Serotonin number 1 so far. The type of drug overdose are mostly influenced by location, sudden drop price, strength of effect, or duration of effect. The answer is location. 5 people got it right. Tengok ranking serotonin. Hakim boleh take over serotonin at point of time. Fourth question. Which of the following is the primary mechanism behind the NMS? The answer is a blockade of dopamine D2 receptors. Wow. Okay, next question. Which of these symptoms is most characteristic of NMS? Answer is severe muscle rigidity. Next question. A key difference to distinguish serotonin syndrome from NMS is that serotonin syndrome has hyperreflexia and myoclonus. Sengit, jangan sengit. Seventh question. Intermediate acid is a metabolite of which of the following compound? All of the above. In the podium. So the eighth question. What is the primary intended medical use of etomidate? Induction agent for GA. Move on to the last question. Etomidate suppresses which hormone system? Cortisol. The answer is cortisol. See the winner. Third place, serotonin. Second place, AA. And the winners goes to Alisa. Congratulations to Alisa for winning this Kahoot competition. Kindly screenshot your Kahoot screen and contact one of our committee to redeem your interesting prize. Ladies and gentlemen, on behalf of the organizing committee, we would like to sincerely thank you, our distinguished speaker, Prof. Khairul, Dr. Yao, and also Dr. Hartadi, for the highly beneficial and insightful speech delivered today. Your sharing has provided us valuable knowledge and perspective that will be greatly appreciated by all the participants. And we also like to extend our gratitude to our sponsors for their generous support, and to all participants for joining us and making this session a success. Thank you, and we will see you guys again for our second episode for this webinar on 16. Second episode will be on 16 October on marine envenomation and also poisoning. Before we end our webinar today, I would like to promote regarding this event, Merbau. We like to, Merbau is an official WAMS official magazine and publisher. Invite to join this Merbau and to submit article for session 4 2026. Next, about the Philippine Toxicology Congress on 2025, in conjunction with 6th International Symposium of Asian Marine Animal and Snake Envenoming Management, which will be held on 3rd to 5th of December 25 at Western Philippine University, Palawan. If anyone is interested, you may register at the QR code provided, and also you can submit the abstract to the symposium as well.